share today?
Sure. Just a quick update from our side. We started our clinical trial with SafetySpect. We had our first patients last week, diabetic foot ulcer. We are very excited about, and we are writing an SPIR grant with Bijan's help with Baylor College of Medicine. That is an exciting update on our side. But going to the speaker today, we were just talking before this meeting started. I know GaitBetter from an incubator I visited in city of Haifa, MindUp, that I am putting actually the link here for those who come after. I'm hoping that MindUp will also have more companies giving talks at this think tank. And so GaitBetter is bringing virtual reality to treadmills, and we are going to have an exciting talk today. And I was very impressed when Hilik introduced the technology to me and how they were able to merge virtual reality with gait and customization of gait for different patient needs. And Hilik is a seasoned executive with different size companies, earlier stage and later stage. And the story of how he transferred an academic work, neuroscience, to a company, and they are already having sales here in US, is a very interesting story. So I will leave it to him to continue on that. But this is going to be an exciting talk. And thank you, Hilik, for accepting to give a talk here.
Thank you very much, and thank you for having me. And I will share my slides. All right. I guess you see it, right? Yes. So good morning again, everybody. My name is Hilik Harrari. I'm a co-founder and CEO of GaitBetter. GaitBetter promotes healthy aging and improves the lives of people suffering from gait impairments using digital neurotherapeutic platforms specifically designed to accelerate and improve gait rehabilitation, prevent falls, and predict neurodegeneration. Okay. Walking is essential for independence. For all the adults and those who suffer from neurodegeneration, who gait, falls, and fear of falling can lead to reduced mobility, isolation, and further deterioration in physical conditioning, which in turn increase the risk of falling. People that practice walking on a daily basis will likely live longer. More important, they are likely to experience healthy aging. Today, by analyzing gait, we can predict longevity and identify early markers for neurodegenerative diseases. Not surprisingly, many researchers are considering gait as the sixth vital sign. One common problem of poor aging are falls. Falls are the leading cause of fatal and non-fatal injuries among older adults. Falls are so common that I'm sure that each one of you knows at least one older person who has experienced a fall. Falls also place huge burden on healthcare systems, accounting for about 2% of the total health expenditure in high-income countries. For many years, falls were associated with natural aging. Researchers and practitioners did not link cognitive skills with walking deficits. In the traditional view, instability and slow gait led to falls and fractures, while cognitive impairment led to dementia. However, over the last 20 years, many studies have shown the relationship between cognitive skills, especially executive functions, to gait. And this is a two-way street. For example, in 2002, Verghese et al. Showed that slow gait predicts dementia. 10 years later, Mirelman et al. Showed that poor executive functions can predict falls. These type of studies reaffirm the notion that motor and cognitive functions work together and affect one another. And if you think about it, and if you think about walking in everyday life, it is very clear why we need both motor and cognitive function. Imagine walking down in the streets of London. It requires constant scanning, planning, paying attention, avoiding obstacles, etc. And therefore, the traditional view on gait and cognitive is insufficient. The current view suggests that cognitive skills and gait function are tightly related. Cognitive decline can affect instability and may lead to falls. People with dementia fall more often and sooner, while people who experience falls may develop cognitive impairment, and so on and so on. So look at the formula of safe gait. It is not dependent only on motor and sensory systems. Safe gait requires cognitive functions, especially attention and executive functions, such as dual tasking, decision-making, and obstacle negotiation to improve gait and avoid falls. To show that, a large consortium of European researchers, led by a research group from the Tel Aviv Sourasky Medical Center, conducted the largest and the most comprehensive randomized control trial ever conducted in the field of virtual reality for gait rehabilitation. The project, named VTime, included 5 clinical sites in 5 countries, lasted about 4 years, and was sponsored by the EU. More than 300 adults participated in an 18 visits training program over 6 weeks. The cohort included idiopathic fallers, people with Parkinson's disease, and people with MCI. Half of the group trained using treadmill augmented with virtual reality, while the control group trained with treadmill only. In the VR group, participants needed to negotiate virtual obstacles while attending to cognitive demanding tasks. And the results were great. Subjects were evaluated before the intervention, immediately after the intervention, and at 1 month and 6 months follow-up. The number of falls, which were the primary measure in the study, reduced by 50% during the 6 months after the intervention compared to the 6 months before the intervention. Twice more effective than the control group. All other measures improved significantly. Gait variability improved more in the study group than in the treadmill-only group, and improvement retained after 6 months. Obstacle negotiation also improved significantly during acquisition and in retention. Executive functions improved significantly, especially at those that had cognitive impairment in the PD group. And what I believe is probably the most important finding is that subjects themselves reported improvement in their quality of life, both after the training and during follow-up in 1 month and 6 months. So we know that that type of intervention is not only effective, but it really increases the person's self-confidence, if you will, that allows them to be more active in the community and feel better about their lives. The VTime randomized control trial was published at The Lancet and echoed among practitioners worldwide. It was this study that prompted us to found GaitBetter. GaitBetter is the commercial implementation of the VTime project, and we continue to expand our clinical efficacy. 5 intervention trials conducted resulted in more than 20 peer-reviewed publications showing the system efficacy in various populations, including in idiopathic fallers, Parkinson's patients, MS, MCI, and even with children with ADHD. Current work includes 2 studies that we're undergoing. One is just completed in stroke survivor rehabilitation, both in chronic and subacute. Those 2 studies are taking place at the Spalding Rehabilitation Hospital in Boston. And another study recently started around mild TBI rehabilitation, and this one is taking place at the Kansas University. We founded GaitBetter at the very end of 2017. As mentioned earlier, we started off our journey at the MindUp Incubator, and we started to commercialize the GaitBetter system in 2020, first in Israel, and since the second half of 2021 in the USA. While COVID didn't really help, to say the least, today GaitBetter is installed in more than 90 clinics in Israel and the USA, and we've treated well over 5,000 patients, and we have installations, just to name a few, in New York University Langone, quite a few with the VA. Oshner Healthcare is one of our largest customers, as well as the two largest providers in Israel, Clalit and Maccabi. So how exactly GaitBetter works? GaitBetter enables motor cognitive training by adding a semi-immersive virtual reality to common treadmills. Our software solution is treadmill agnostic. It transforms any existing treadmill into an intelligent and personalized motor cognitive training system to improve both mobility and executive function skills. We place a single depth camera in front of the treadmill and track feet movement in real time. The trainee is walking on the treadmill and see her own feet movement in a simulation displayed on a TV screen. As she walks, she needs to negotiate virtual hurdles to exercise step clearance or step height and cross puddles to improve step length. In parallel, the trainee must attend to cognitive demands. She needs to remember things she sees along the way, make decisions, navigate to different locations, and relate to different attention distractors. The GaitBetter technology includes three main technology pillars. We use a proprietary computer vision algorithm to very accurately track the 3D motion of the feet in real time. This boosts motor learning skills. We created an AI-based training program, a training algorithm that can automatically adjust the training protocol to the individual. And finally, we gamify the training. Not only does it keep our users engaged, it simulates real-life situations to increase transfer of the acquired skills to real life. We see about 90% adherence to a training program among our patients and trainees population. Here are results of one of our early customers, Maccabi Healthcare Systems. Maccabi conducted a large pilot that included 200 adults, all with high risk of falling. Like in the V-Time project, Maccabi followed up with the patients for 6 months post-intervention and compared to the 6 months before the intervention. They've seen 71% reduction in number of falls and almost 50% fewer visits to emergency rooms and 34% reduction in hospitalization days. Maccabi didn't even wait until the official conclusion of the pilot before placing a large order of GaitBetter systems, now installed in more than 25 locations across the country. We are on a quest to support healthy aging across the spectrum. Today, we have 2 products in the market. GaitBetter, the medical edition, is an FDA-registered medical device. It is sold or licensed to rehabilitation and physical therapy clinics, and it is being used in rehabilitation service, where therapists can really tune any aspect of the intervention to fit to the individual patient's needs and capabilities. I'm actually today happy also to announce that just a couple of months ago, the AMA approved our filing for a new CPT code for the GaitBetter service, which will become effective this coming July. Gait Active is our non-regulated wellness device. Typically, it is licensed to senior living, day centers, and even regular gyms. And now we have started to design our home edition solution for GaitBetter, name is still TBD, which I sometimes call Peloton for all the adults. Pending additional funding, we expect to launch our home edition sometimes in 2024. But there's a bit more, and I think you'll find that exciting as well. Another exciting area that we are investing in is motor cognitive reserve. Our research partners from the Tel Aviv Sourasky Medical Center utilized our technology platform to create a stress test that measures the reserve capacity of a person's motor cognitive capability. The idea of cognitive reserve really refers to the brain ability to operate effectively even in the face of pathology. The test, the MCR test, it takes about 20 minutes, and it's made of various motor and cognitive challenges of different difficulties. It uses a validated AI model to calculate an MCR score. The validation included more than 500 people, healthy, and people with Alzheimer's disease, Parkinson's disease, MCI, and Lewy body dementia. The system was able to differentiate healthy from non-healthy at more than 90% accuracy. We believe that MCR score is a predictive marker for many and different neurodegenerative diseases and conditions. To show that, we are supporting 3 clinical trials. The first one is a longitudinal study in which we track early-stage Parkinson's patients over time. Subjects perform MCR tests every 6 months, and we are looking to see correlation between the MCR index or score to the progression of the disease. The second one is shorter in nature, and it's also focused on PD patients, specifically PD patients that are undergoing DBS operation. About 30% of those patients will experience a rapid cognitive decline within the 12 months following the procedure. We are performing MCR tests before the operation and looking to see if MCR index indeed predicts cognitive decline post-DBS. And the third one, which is the quickest one, and we expect to have results even before the end of this year, is we're using MCR as a predictive model for post-operation delirium. In this trial, all the adults who are scheduled for an operation that includes 2 hours of full anesthesia are taking an MCR test before the operation, and we're looking to see if MCR indeed predicted delirium post-operation. We already collected data from 50 subjects and looking to reach about 200 tests before evaluating the results. With that, I'd like to thank you for your time and for inviting me today this morning, and I'm happy to answer any of your questions.
Wow, that was amazing, Hilik. That was great. I didn't know that you worked with Jeffrey Hostroff. Actually, I had the opportunity to meet with him several times. For those who doesn't know, Jeffrey Hostroff, who was senior author of the Lancet paper, he is truly a leader in the area of the gait assessment, and he came up with the idea of the fractality of the gait variability that provide a completely different dimension for gait assessment. And that's amazing. I echo you in the importance of having some kind of the real feedback to the patient that can enhance the perception of the motor error that patient is doing. The reality is that our brain has amazing plasticity, but for learning, our brain needs to perceive errors, and having those kind of virtual environments that for patient actually engaged in some of the realistic scenario that can help to perceive what are the errors that you are making might be a new generation of physical therapy. And I believe that has a great prospect in this area. I have a question for you. In some of the, of course, extra game that we are using is a combination of game and exercise. It's not as sophisticated than yours, but you find out the great benefits for reducing depression, and particularly in the aging population and frail population. And I discussed with some of my colleagues who were in psychology and say that usually if you having some goal-oriented task and patients see that it can get some score, some benefit, like a gamification mentioned, this is the one of the effective intervention to manage depression. Have you looked at your database that what is the benefit of that intervention to reduce depression?
So we personally in GaitBetter is less focusing in that area. I know there are quite a few companies doing that very successfully. And I believe, in my perspective, virtual reality, right, as we use technology in different ways, it can be leveraged to different goals. What I've seen specifically around depression is, and maybe I'll touch on that because it's also related to the extra gaming comment that you made. I think the big difference between how do you use technology and for what purpose. So, for example, when trying to deal with depression, the simulation can be very cheerful. It could, it doesn't really require replicating or simulating daily activities. When we've created our own games, and that started with the V-Time project, and we took it further on by adding additional scenarios, we're really trying to almost simulate the exact same scenarios that an ordinary person will experience in real life. Walking down the street, walking in a city park, going to grocery, right? So we're really trying to replicate and put them in that type of scenarios that they are likely to face later on. We actually sometimes get letters from patients telling us, oh, I walked in the street and I remember my GaitBetter training, how to negotiate an obstacle. And this is what I meant by focusing on building that transfer capabilities, right? How people transfer the acquired skills into the real world, and that's what we see.
That is amazing that you mentioned that. Actually, we have exactly a similar quote from our patient who has diabetes peripheral neuropathy. And she told us before, actually as a result of the outcome, as outcomes of the intervention, she said that I love dog, and my passion, my quality of life I define now that I'm retired is to be able to walk my dog. But one time when I walked my dog, the leash of the dog turned around my feet, and I was paralyzed because I didn't know how I can lift my leg to pass from that leash. And that scare, it caused that I hired someone else to walk my dog for me. And that was devastating for me. And then using the simple gamification that we use, as you mentioned, is creating that scenario that she can overcome that fear and learns how to do obstacle negotiation. And the note that I got, the card postal from her, is that she said that now I continue again to walk my dog, and it seems that my life is back. So I really echo you on that direction. But I would like to come up with some challenging questions. This is what I dealt with it. When I talk with physical therapists, for them, exercise is either resistive exercise or aerobic exercise. Those kind of exercise with real-time feedback is not very well known for physical therapists. How you pitch this idea to physical therapists that maybe that's a new category. It's not necessarily resistive, it's not necessarily aerobic, maybe have a piece of them, but how you pitch them and how you think that the physical therapists may adopt this new kind of the physical therapy for their patient.
I think that market education is a big challenge for companies like us, and many of those that using neurotherapeutics and gaming to improve health. Actually, if you think about it for a minute, in many cases when we meet potential customers, physical therapists think motor skills and motor intervention, and occupational therapy think cognitive. But reality, as we started off the presentation, is not like that, right? We constantly use both. So part of our challenge is indeed to educate the field with that new modality that more and more companies are engaging by involving more than one aspect of the therapy to lead to better outcomes. Vijay, I have a few interesting questions on the chat. Maybe I can address some of these
exactly.
as well.
Yes, I would like exactly go into the chat. So Marge asked about the application in ALS. And Marge, please.
Right. So
I just wanted to preface it with I find the connection between the cognitive and the motor skills to be really fascinating. That's not something I have studied in the past. I don't even know if that makes sense within the context of ALS. But we have a study going on right now with ALS patients, and maybe we could maybe we could somehow work with you.
So that would be that would be very interesting to explore. Unfortunately, we know that with ALS, it is, I don't know to what extent anything can help. Unfortunately, what we've seen with some Parkinson's patient is that progression, or MS patient, is that progression slows down. I don't know to say if that would be the case with ALS, but it would be interesting. One point that I will mention, and again, I don't know, and I can consult with our colleagues at the Thoracic Medical Center about that, and maybe even linking back, Jen, to what you said before. One of our 2 or 3 of the studies of the 20 peer-reviewed publications that I mentioned earlier, we're looking at brain plasticity post-intervention. We did fMRI and fNIRS post-intervention. And what we've seen, even in older adults, even more with patients with cognitive impairment, is that, yes, there's certainly brain plasticity, and even an extensive one following that type of intervention that also retained months after the training. Would that support ALS patient? That is something that I guess we'll need to explore.
Thank you. Actually, Misha asked a great questions. Of course, when you have a real-time feedback, the latency is a major concern. So, Misha, do you want to elaborate on your questions? And Hilik, actually, I appreciate if you can talk about latency and how you should address that challenge for your technology.
I think you pretty much voiced already the question. So, I mean, in my past interaction with this technology and attempts to implement the biofeedback, we were finding out that the latency is critical for, I mean, if you really want real-time correction, you're feeding the brain with the wrong latency, the brain is learning the wrong latency, and then it causes the problem when you try to remove the gadgets and work. So just any comments on this front will be welcome.
Yes. So Misha, this is actually fascinating, right? Because and it's kind of interesting to think about it for a minute. So first, you're absolutely right? You need to make sure that the patient, when they move the feet, it moves on the screen at basically the same time. We worked really hard, and this is part of our proprietary technology, that we achieve under 0.3 second latency, about 0.2 seconds latency. You may still feel a bit of a gap, just a little, right? But here's something very interesting that we found. It's actually not that bad. It's actually adding half a second later and your step is way off, then that won't work. But if it's a blink of a second, and it's about 0.2 seconds, brain need to fix it. It's actually adding another level of challenge for the patient, because they need.
Oh gosh, it seems that we lost you, Hilik. The network seems weak. I don't know that it's working.
I think I'm back. I think I'm back. Can you hear me? Hello?
Yes, it's dropping a little, but now I'm hearing you.
Yeah, sorry about that. And what happened is that I lost questions on the chat. But yes, so what I said is that a 0.2 delay is actually not that bad because the brain need to compensate for that as well. It actually increases the difficulty even more.
Okay, great. And Abedu actually also he has a questions that it asks for some of the patients who may be frail, may have musculoskeletal problems, and may have a challenge to walk on treadmill. What are the solutions for those patient population? Actually, those are the patients that get the most benefit from the exercise. And Abedu, if you would like to elaborate on your question, please open up your mic.
Right. No.
Yeah. Well, thank you, Bijan. And sorry, my camera is not working, but excellent presentation. Yes, it's exactly what has been already said that in terms of the challenges. And another related question with that is in how long they have to be trained to actually to have significant benefits. And also, can we determine, what change would be, something that would be acceptable, that yes, the intervention has made a big difference.
So I'll address the few points that you brought up. First, with respect to the training protocol, typically what we recommend and what we've seen in the different studies is that peak efficacy comes around 15 visits. And we do recommend that the intensity of the training will be at least twice a week. So our program involves twice a week, 2 visits per week. Each visit is about 20 to 30 minutes long, and again for 15 visits. Some of the organizations that we are working with will provide maintenance program, typically once a week, even after the initial training program, to maintain and to continue to enhance function. Another note on that, the papers that we released, is that motor skills are kind of flattening out around 18 visits on average, but cognitive continues to improve the more that you do. So we would recommend to continue to do the training for those, specifically those that suffer from cognitive decline. Regarding safety and motor skeleton, so a couple of things, right? One, you notice that we are putting a harness system on the patient as they walk. This is used only, our harness is used only for safety purposes, and you would be amazed how much just putting something on the person increases the self-confidence and gives them that confidence that, yes, I can walk on a treadmill, because people can't imagine that they can do that. I've seen patients that are literally cannot, they wheel them on a wheelchair to the treadmill, put them on, and they start walking, which is just amazing. Some of our customers, however, will use even a weight, an unweighted training harness systems. They tend to be significantly more expensive, which we do not provide. But many of our customers have that in the.
I seem that again we lost you, Hilik. Is dropping.
Oh, sorry, I'm
no worry,
so sorry about
that. Most essence part. So, of course, in point of view of, I'm guessing duration of training, I'm guessing there's a theory in neuroscience that they said overlearning. That means that you can quickly learn some skills, but if you would like to retain that learning, that motor skills, you need to extend. And more you practice, more you have overlearning, the likelihood of retention of that trophy is better. John Paul, I'm seeing that you're raising your hand. Please go ahead and ask your question.
Thank you.
Yeah.
So thank you. So one of the things that came to mind when Bijan told the story of the dog is that also walk with our upper limbs, right? And so on the treadmill, people are a bit immobilized. Now, you're getting this right 90% of the time. I understand the feasibility issues with the treadmill, but I'm wondering, would you consider using sort of a tetherless system? Let's say, well, with the harness, that would be important, but to put people in the room, when they experience those obstacles that you show, so they have to navigate through the environment, they're using this sort of translatory motion, right? So when you program your stimulus, it's translation, it's shear, it's rotation. When we walk through the environment, we need these sort of perceptual skills. So to take it to another level, I was wondering, I mean, to have a room where, again, people don't have to immobilize their upper body, I'm wondering if that would have value. I understand that this can be adapted to any treadmill. I understand that you have the camera on the foot sensors, but are you going sort of beyond that? I can envision something with a headset, let's say for the stimulus, and a tether. Again, there needs to be someone near the person, but that would sort of recapitulate the experience of, completely walking with your arms. And is that something you're thinking about?
Well, the answer is yes, not necessarily in this way. There are different ways to address that. If you're thinking about headset, I didn't mention that in that presentation, but notice that we are not using the fully immersive. I don't know if you ever had the chance to try that, but put on the goggles, try to walk with them, you will lose your balance immediately. One way to go about that is to use augmented reality. Technology is not, there's some great progress in the augmented technology space. It's, the cost is still quite expensive and we haven't figured it out. But yes, looking at upper limb is really important. The way that we are thinking on solving that, and it's something that we are looking into, is to add another camera to look at the upper body. But I would like to mention something to the group, because I think that many of the questions kind of circling around the same topic. I believe that there is a big gap between what researchers and folks in the call and many of the folks that I'm working with, have these brilliant ideas to advance research, to advance science. But healthcare systems do not work like that. And we need to figure out how can, well, I hate to say it, how we can help them make money eventually. That's why we're pursuing CPT codes. That's why we've decided to do that as an add-on to existing treadmills. So keeping the investment cost very small, right? Because we believe that it needs to be in any exercise room. Having $1 million system that occupies a whole room in one hospital, that's great for science. It doesn't improve healthcare.
Well, I wanted to
This is a
say,
really valid point. Actually, I would like to, sorry, Jean-Paul, actually, now that you touch on that one, of course, what is the need for treadmill? Do we need to have treadmill or not? Maybe for some of the patient, they can do marching in place and observe negotiation in place. And also Warren mentioned for testing balance, maybe can do for quantifying postural control. So what is the need for having treadmill? And also if you can touch base a little about the costs, whether these CPT code that are nothing, it's already a small reimbursement that justify that sophisticated technology, and still physical therapy or occupational therapy can get money out of it.
So treadmill allows to get significant amount of steps during training. We have 60, 80, 90 years old people will walk for a mile in a training. They would never, ever do that in the hallway of a physical therapy going back and forth. Actually, one of our customers, Faye Bronstein, she's a physical therapy at the New York University Rusk Center. She published a poster and her work about how she was able to increase dosage of walking, as she calls it, for stroke survivors rehabilitation by using treadmills augmented with virtual reality, because when you walk and you inside a game, you're really into that. You forget about your problems and you walk more. Regarding gait parameters, so we do provide some parameters, not everything, but this is something that we're certainly investing in. And by the way, this is one of the capabilities that differentiate between our medical device, as I mentioned, GaitBetter, and Gait Active, which is the wellness edition of that. In the medical edition, we also can provide symmetry, viability, cadence, and other type of gait matrices that physical therapists are interested in, which we're not providing in the non-medical version.
And
John will ask the question, but also the cost.
And price, yes, I did not. I didn't want to ignore that. Absolutely. So it is much cheaper than you can imagine. What we are, the way that we sell it for, or we don't sell it, we actually license it. So it's under a DAS model, device as a service. We provide all the equipment that you need, which is a camera, a PC, the mount that puts everything in. And the cost is, the average cost is around $7,500 per year. The CPT code that the AMA granted, we are now negotiating with Medicare around coverage and payment. And we're shooting for anywhere between, it's an add-on code, right? It's an add-on code that will be submitted together with gait training. And we're looking to for anywhere between $10 to $15 add on to the existing code, right? And with the, that means that with a very, with an average utilization of roughly 2 trainings per day, providers will see a return of roughly $10,000 per year, right? So ROI is there.
That, of course, there is a renting of the room that sometimes in some of the clinic also could be expensive. And
well, I'll tell you that until now, between the 90 systems that we have installed, I believe maybe 1 or 2 did not have treadmills already in place. So 99% of our customers, I can say, has those treadmills already. And we don't care what type of a treadmill you have, right? You can have it large, big, small, whatever it is. We just place a camera in front.
That is smart. John Paul, sorry, I interrupted you multiple times. Go ahead, sorry.
Well, no, I just wanted to acknowledge the caveat that you guys are getting this right 90% of the time with what you have right here. So the predictive validity is very high. So it's hard to improve beyond that, but I just did want to acknowledge that. Hilik, I realize that what's coming through is just 90% of the time you're able to predict things. So yes, I just wanted to say that.
Thank you. Thank you. MCR is amazing. And I'll tell you that around MCR, motor cognitive reserve, there's definitely room for collaboration around extending our research, and we can connect with our partners at the Sourasky Medical Center because they have many ideas of where, what type of other studies and exploration we can do around MCR.
That's great. So I'm guessing you're covering all the questions, but I attempted to ask 2 more very quick questions. Please. I know that we passed the time. One question, of course, there is a challenge to say that maybe overground walking, treadmill walking doesn't mimic necessarily overground walking. And when you train somebody on treadmill, how it can translate to walking on overground, it might not be the same. And the second question, since you're targeting the people with cognitive impairment, many of patient cognitive impairments, there's report that they miss their follow-up visit in clinic, and that's significant loss to many physical therapists because it's reimbursable, but those patients seems to rely on somebody else to bring them to the physical therapy. Often they are not attending in the follow-up sessions. And how you addressing those challenges? So start with the end, right? So first I will mention the inclusion criteria to be eligible even to train using the system. You need to have 2 basic skills. One is that you should be able to walk, right? In inpatient, we typically ask for at least 1 or 2 minutes. By the way, with or without assisted device, but without a person holding you. So you need to be able to walk. And if you have a cognitive impairment,
you need to at least be able to understand instructions. So severe, later stage of Alzheimer and more severe dementia, we are not treating these type of patients, right? So we really want to treat people early in a disease, or frankly, in many cases, the healthy adults, just working on aiming for prevention.
I was hoping that you mentioned that you may use for them a telerehabilitation that can install the patient at home, and maybe during 12 weeks you provide the system and your team will collect their system back when the 12 weeks has been finished. But this is not in your business model currently.
Correct. And I will say a word about overground walking. You're absolutely right. Walking on a treadmill is not the exact same thing as walking on a ground, right? Obviously, the treadmill is moving. So this is something that while it may be important to, almost all of the studies that we've done, we compare results over ground testing, right? So what we see is that when you train on a treadmill, you also improve in your overground training. All of the tests that we've done pre-post intervention were overground testing, never on a treadmill. If you think about it, and I'll say a sentence with that. We have a say in the Israeli army that it's train hard. It's in English it exists as well, obviously, but train hard, right? And it's easy in combat. Same idea here. We train harder on treadmill. The belt is moving. Things are moving ahead of you, right? Virtual reality obstacles are coming at you. You constantly need to engage. Then when you're walking on the ground, yes, you can stop, right? When you're reaching an obstacle, yes, you can stop. You cannot do that on a treadmill. So practice hard, it's going to be easier in combat.
Thank you so much. That's amazing. It's great analogy. So thank you for your patience to addressing all the questions. Thank you, everyone. Yes, Marge, go ahead.
Oh, just a quick question. You had listed in your plan a goal of eventually doing a home-based system. So that would fit the model that Bijan was talking about. Can you say more about that?
Absolutely, yes. We believe this solution needs to come to people home because, also not only because also healthcare systems around the world and in the US say it's hard to adapt new technology. It takes time and it's a struggle. We believe that home, having that type of a solution for people at home will make a lot of sense, and we believe that we will. So we do have a few, I call them beta customers that use it at home with really splendid results. This is something that in design, we're looking to launch it in 2024. Doing a B2C, just back to business, right? Remember, I'm still more than a researcher. I'm running a company. Doing a B2C business is significantly different than a B2B and requires some significant funding to scale, successfully.
That's great. Of course, as you know, telerehabilitation, some of the states in the US, they have the same reimbursement that face-to-face physical therapy. And the fact that you don't need to take any space in clinical area that often is very expensive, and the person maybe through your screen can have the telemedicine. The physical therapist might be another way to consider. I'm very happy that actually this is in your plan for 2024. And that's also great, overlapping with C2Ship mission. Maybe C2Ship can help you to bring and adopt your technology for telerehabilitation purpose as well. Thank you all. Thank you so much, Hilik, for your time and excellent presentation. Happy Friday to everyone, and see you all next Friday.